Welcome, everyone. Good evening. This is the July 2024 edition of Eversight's webinar series, Why Office-Based Surgery with Parag Majmudar. Just a few quick housekeeping notes before we get started. This webinar, all of our webinars are recorded, available on demand on YouTube via our website. Please keep an eye on your inboxes for more webinars coming later this year. Next, we have applications of AI in cornea with Travis Red on September 25th. All participants will be muted throughout the duration of the webinar, but please do ask questions. You can do so at any point in the talk using the Q&A panel at the bottom of your screen or the bottom of your phone. And then Dr. Majmudar will answer questions at the end of the talk. And so now just a quick introduction for Dr. Majmudar. After receiving his medical degree at the Medical College of Pennsylvania, Dr. Majmudar completed ophthalmology residency at the University of Chicago and subspecialty fellowship in cornea, external disease, and refractive surgery at Rush Presbyterian St. Luke's Medical Center in Chicago. He is an active participant in clinical research. Dr. Majmudar is a highly regarded lecturer and instructor on the subjects of corneal and refractive surgery. Currently, he serves as an associate professor of ophthalmology at Rush University Medical Center in Chicago. And additionally, he's a longtime partner of ours at Eversight and the one who got us to preload the Dork Tube for DMEC. So if any of you on here are Dork Tube DMEC users, you can thank him for that. And now I will turn the floor over to Dr. Majmudar for the talk.
Great, thank you. Thank you so much. Thanks for taking the time. Everyone has very busy schedules, but I appreciate the time and the interest. When Michael first emailed me, he said, can you do a webinar on office-based surgery? Please give me a title, for the talk. And in my typical fashion, when I'm doing 1,000 things at once, I sent back a quick email reply, three words, and it was why office-based surgery ? And then he emailed back saying, well, I think it's a pretty good topic, and I think people might be, interested in it. And I was like, no. That is my topic. That's my title. So here it is, why office-based surgery. So today, in the next probably, 20, 30 minutes, what I'd like to talk about is why we made the transition to doing surgery, not all of our surgery, but a lot of our surgeries in the office. And is that viable? How does it work? What is the benefit? And I think we can kind of, explore some of these options or some of these topics today as we go through the next few minutes here. But once again, thanks to Eversight for allowing me to participate in this webinar. So I think that we are facing a problem, and it's a good problem to have in a way, because we are having an explosion growth of people in our country that are going to be above 65 years of age. And we think that over the next 10 years or so, the number of cataract surgeries that we're doing are going to double as a conservative estimate. And we're already doing a lot of surgeries in this country, and it's the number one procedure that's being performed on Medicare patients. But I think, imagine if we are doubling that or more, we need to be ready for that. Now, the problem also is that we're almost kind of facing a perfect storm of sorts, because even though we have this growth, and we're seeing it even now, that our cataract numbers are increasing year over year, we're starting to get trouble from our surgical facilities, whether you operate in a hospital or whether you operate in an ambulatory surgery center. Many of those places are sort of pushing ophthalmology out. And you may see this, maybe not if you're an established surgeon, but some of our newer surgeons have difficulty getting OR time. And the other issue is that the ASCs are often driven by bottom line, and what they want is the higher paying, lucrative surgeries like the joint replacements and pain and gastro. And those, maybe one joint might pay more than doing 20 cataract surgeries. So I think we're starting to see a little bit of a shift where we are having we're going to have this problem. How are we going to do all these surgeries? And so we think that office-based surgery may alleviate some of that backlog, depending on how you position it within your own practice. The other issue, too, is that for a practice like ours that does a lot of elective procedures, so things like implantable Collamer lenses, phakic intraocular lenses, refractive lens exchange. When we're doing these procedures, there is a significant facility cost that is incurred by the patient, but again, costs are passed along to the patient where they have to pay a significant cost to the ambulatory surgery center, for example, or the hospital. And in that situation, unless the surgeon is a full 100% owner in that ASC, and there are many places across the country where that is the case, then that may be okay. But for the vast majority of us who don't have sole ownership of an ambulatory surgery center, those are, fees that are being, driven away from your own practice. So there is definitely a financial component to how we envisioned establishing an office-based surgery solution. So the solution is really that many of the procedures that we do can be performed safely, effectively, and not only effectively, but cost effectively in an office-based environment. And that comes with some caveats too. We're going to talk about that a little bit as well. However, there are more than 7,000 private practices, ophthalmology practices in the US, but probably less than 3%. We think maybe a couple of hundred office-based suites are in existence in the US, and that is an extremely low number. And the potential for that number to increase is very, very high, and it may be driven by a lot of different factors outside of our control, regulatory and other types of things, which may be a situation where we are ripe for performing office-based surgery. So, but why is that? Why are we not doing more cases in an office-based suite? Well, there are a couple of barriers, obviously. One, of course, that plagues all of us from time to time is really inertia. That hey, we're doing fine, everything's good. Things are the routine is established. We don't want to upset the apple cart. However, we just there are things that if you can open your eyes and see that the possibilities really will kind of amaze you. Second issue really is kind of a fear of change or fear of outcomes or safety. We definitely don't want anything that's going to create potentially higher risk of complications for patients. Maybe it's too much of a hassle to set it up. Maybe you don't have the space. Maybe you practice in a private equity setting or an academic setting where you may not have a luxury of doing some of these things as if you are in a private practice. There's also, of course, regulatory issues by the states. A lot of states, including the state I live and practice in, Illinois, we have certificate of need laws, and certificate of need indicates that, if you don't have that document, that there is really a need for you to establish an independent medical facility, then the state won't allow you to be a licensed facility, which means that you can't operate and do any cases that use government money, including Medicare, Medicaid, so on and so forth. The other sort of trouble that we sometimes get into is it's like, how do I even start? How do I even get one of these things? How do I build it? How do I manage it? How do I get proper documentation? How am I going to get paid? How am I going to get insurance contracts? How am I going to deal with all the regulations in terms of safety and tracking and how am I going to hire people to run? I mean, there's a lot of things, no question. There are a lot of things, but it can be done, and we are proof that was the case because our journey, started about a journey started maybe 2 years ago, but we started doing cases in our office-based surgery in September of 2023, and it's almost a year, and it has taken off much, much faster than I anticipated. We know based on our experience that we can do a office-based setup for a surgical practice at a very minimal cost compared to building an ASC. Typically, ASCs cost anywhere from, if you have, let's say, a 2-room ambulatory surgery center, you're probably going to be looking at $3 to $4 million. And of course, you need the certificate of need. The advantage of an office-based surgery suite is that if it's done correctly, you can do it for much, much less than $3 to $4 million. I would say, probably in the order of $600,000 to $800,000, for example, would be. So you're talking about 25% of what it would cost to do an ASC. The other advantage, of course, is now, we have those patients that we're doing a lot of elective cases, and we're having to pay the facility for that. We can retain some of those fees, and that certainly adds to our own practice profitability. Surgeons can also capture facility fees from commercial insurers, because a lot of them have out-of-network benefits that you can tap into. And ultimately, some of them may go the route of allowing office-based surgery because they're going to see eventually that it is maybe more cost-effective for them to do that. And I think Medicare is going to follow suit. I don't know when. I don't know if it'll be in 2 years, like they're planning in 2026 to have another, a review, whether it'll be 27 or 28 or 30. I think they're going to come around to allowing this. We see this in all other countries where an office-based system is pretty much the norm. And an independent practice will have an office-based surgical suite on that floor or the floor above or below, whatever it is. And it's a very efficient way of doing things. And I think that we will see this. Now, for those who have, for example, residency and they practice a licensure in a state that does not have certificate of need laws, you may be able to do an office-based surgical suite and almost have it be like a mini ambulatory surgery center right from the get-go, where you can do all of your cases. You can do Medicare, commercial, elective, everything right from the get-go. And that is an advantage of living in a state that doesn't have CON laws. I think that our growth of our cash paying segment, ICLs and premium lenses and refractive lens exchanges, have increased by having an office-based surgical suite. And how is that? Well, really, it's the fact that you're offering sort of a boutique customer experience. You're offering customized cataract surgery, for example, or a customized, procedure in an office-based setting that is geared toward that patient experience. Very different situation than going to a hospital or an unknown surgical center. You don't know any of the people. They start, sticking you with needles. And you're already anxious. Now you're even more anxious. You maybe require even more, sedation. So there's a lot of different things that go on with this. And what we've seen is that patients are very, very comfortable with this process of having surgery in a very familiar location. And the fact is that we're kind of taking back, surgeons have kind of been marginalized. We kind of have to, deal with hospital bureaucracy and ASC bureaucracy, government bureaucracy. And now we can kind of have a voice in how we're doing things. We can actually decide, hey, do I want this microscope or that microscope? Do I want to have, a 3D visualization system, which we opted to have? I was trying to get my ASCs and hospitals to purchase one of these for the last 10 years, since they became more, sort of mainstream, and I've just been unsuccessful. But in my own center, I can set it up very easily, very cost effectively, and it has immensely changed how I practice medicine. So I think the biggest kind of barrier that people really have is that office-based surgery, in their mind, it's not safe. But I think it is, and we have definitely proof of that with many different organizations that have started to do office-based surgery. The main thing that I want to stress is that this is not a sort of a back alley surgery. We're doing this not in just an office or a closet, or where we just have a roll in a bed and bring in a phaco machine and start doing surgery. This is a very, very high quality, accredited mini ambulatory surgery center. So our data and the data that we've seen from a lot of the sites across the country, there's a big study that came out of Dan Dury's group, 47,000 cases over 57 sites, all across the spectrum of ophthalmic surgeries like cataract and lens implants and retina, glaucoma, cornea, et cetera. They had a very, very, very low incidence of adverse outcomes. And that is very, very similar to what you would see in an ambulatory surgery center. In that study, there was one case where they had to call 911, 2 cases where the patient had to be referred to a hospital. Things will happen. Patients will have, medical events from time to time. In my opinion, it's not very much different than if you had a patient in your office who was getting a minor procedure or having an eye exam and they had a medical event. So we can employ those same types of procedures to get them to the right level of appropriate care. Now, I will say that, if you are going to have an office-based suite, it behooves you, and by accreditation laws, you have to be certified in advanced cardiac life support. You've got to have all the defibrillators and the crash carts and everything else, and you should know how to use them, because you do need to be able to initiate resuscitation if there is an untoward event. But I think that's a very, very good thing to have anyway. There was another study that was done where they looked at anesthesia patterns in 11,000 surgeries at 32 centers. And this is another area where we say, well, do we need to have patients zonked out or put to sleep for cataract surgery? And the answer is, by and large, really no. 95% of the studies in this study, the cases that were done with Class A oral, which is just maybe a Valium or a Xanax or something along those lines, and topical anesthesia drops. For the past, probably at least 20 out of my 28 years, I've probably done 99% of my cases with very minimal IV sedation when I did them at the hospital or surgery center. And even now, I don't ask the anesthesiologist or the CRNA to give more than 0.5 of Versed, and that's it. And then I use topical drops. I'm talking to the patient. Fortunately, a lot of the surgeries that we do aren't very long, 10 to 15 minutes, and most patients can do very, very well with this sort of pattern. And so we were able to kind of transition that over to our office-based system as well, where we don't require IVs, we don't require CRNAs, because we're doing all Class A oral topical. Now, that means that we are selecting patients who are in that mold. We're not selecting very old patients. Again, in Illinois, we don't have a certificate of need in our center, so we're not doing Medicare patients. So most patients are under 60, all patients are under 65. Generally, they have to be Class 1 or Class 2 ASA, American Society of Anesthesiology classification, as far as surgical risk. And I'll tell you that of the few hundred, probably 300 procedures that we've done so far, all of them have handled it pretty well. Most patients require maybe one tablet of Xanax and maybe another supplement if they need it. But most patients going into the operating suite are very, very comfortable, and they're very happy, because I think that there's a level of anxiety that they don't have by being in a familiar place, seeing familiar staff, knowing the environment. And it's just a very, very, as I said, boutique customer-centric experience. I will make a note that a lot of surgeons do use those MKO melts, the midazolam and ketamine and ondansetron for the nausea, but they use that mixture as a melt sublingual. In most states, that ketamine does put you as a facility into a Class B. So you have to be careful, kind of, if you use it in an office-based suite. If you don't have someone who is a certified nurse anesthetist or an anesthesiologist, and you're not doing the appropriate level of monitoring, you could get into some trouble there. So just be careful about using ketamine. So we don't use that in our center, because we've elected at the moment to be Class A. Now, it doesn't mean that we can't go to Class B certification at some point in the future if our demographic changes, if Medicare will allow office-based surgery, and now we're doing higher risk cases. That's certainly a possibility to do that, but not necessary. I think from what our experience has been, is that we've been able to do our cases in our office-based system and do them with Class A topical oral, and they've done very, very well. There's a study from IOR that looked at 18,000 cases, and they looked at patients as a subset that were 65 years of age and older. And you can see that the risks or the incidence of endophthalmitis and unplanned vitrectomy, return to the OR or referral to the hospital, has been very, very low, and it would rival probably any ambulatory surgery center that you currently may be operating in. So as I said, these complication rates are similar to what we see in an ambulatory surgery center. I stress that these are not done in just a utility closet. This is a fully state-of-the-art, certified, in our experience, they should be certified ASC quality or better facility. And I think that is certainly something that is not mandated these days. So you see all kinds of quote unquote office-based suites out there, but my philosophy and the philosophy of our team is that it has to be an ASC quality facility. Otherwise, no go. We want to ensure the highest level of quality equipment, quality certifications, quality standards, and we need to just do it the right way. As I said, all of our providers are ACLS certified. We have an automatic defibrillator, crash cart, up to date, and we are able to, if God forbid there's an issue, provide at least some support until emergency services can arrive. Now, luckily for us, our LBS and our office is right next to a hospital, and so we're in that sense we have the good fortune to be close by in case something happens. But I will tell you that when we first started this whole journey, it really was more of a financial sort of pull. I wanted to recover some of the costs that we were paying for elective surgery. I had some cases where we would do a procedure like an ICL, and there was a problem with maybe the lens rotated, it was a toric lens, or I needed to exchange the lens. Well, now I've got to pay another fee to the facility, and they weren't very they were not happy to do it for no charge. They would charge me a full price again. And so pretty quickly you find out that if you have a few of these, really affects your bottom line. So that was my sort of initial thought process: is, hey, let's do something where we can do this in our own space, do it carefully, and do it the right way to the right highest standards, and maybe it'll save us some money, and maybe we can kind of increase our profitability. But I quickly found out that this is really a patient-centric process, and patients prefer having their surgery in a state-of-the-art facility, which they can see ahead of time, which is in our office. The staff that they know is going to be in there with them. There aren't these hassles and hoops that you have to jump through when you have to go to an ASC or hospital. Again, we're doing Class A anesthesia, so we're not using an IV. Patients don't need to fast. They require less sedation because they're not, as I said, as anxious, because they're in a situation where this is just a very, we have a massage chair for them when they're in the pre-op area, and then they are coming into the OR relaxed. And fortunately, our procedures that we do are pretty fast, they're painless, and most patients are doing great. The other thing that we found is that, as I said earlier, it's getting harder to schedule cases in a ambulatory surgery center or hospital. So I remember a few years ago that somebody would come in for an evaluation for, let's say, a phakic IOL, for example, and I would say, well, okay, I think you're a good candidate, let's do this, and then my coordinator will call you. I'm probably booked out a month or two, before I can get you in, and that kind of, you can see the interest level sort of, now the OBS is in our office. Now, because it's still new, we're only doing probably 300 cases the first year, which is not tremendous. If you think about it, on average, that's probably one case a day, or a little bit more. So, it's easy for us to say, hey, you want surgery Friday? Sure, let's do it Friday. And for me, I can come in the morning, do a case, and then go see patients right there. Or I can do several cases. I can, do a surgery, go see a few patients, come back and do another surgery. And some doctors have been doing this in other parts of the country for a long time. And boy, did I envy them. And now I feel like now we're finally able to offer the same type of convenience. And patients love that level of convenience and this whole customer experience as we're talking about. As we talked about, the financial aspects are there. We can control our costs much better. As we were saying, we were paying for an ICL or a refractive lens exchange. We were paying close to $1,800 per eye for use of the ambulatory surgical center. Our costs are less than $400. And so that is a tremendous savings. If we need to do an exchange or a rotation, well, again, it doesn't cost me another $1,800. It might cost me, $200-300 or something like that. And so that is definitely an advantage. Plus, you see your practice grow. I see my practice grow for premium lenses, for elective surgeries, because of this experience, and the word of mouth is getting around in the area that this is an amazing facility, and it's a great way to build a practice for sure. Again, depending on where you live, if you have CON laws or not, you may be able to contract with various payers, even Medicare in certain states where a certificate of need is not required. And then in that case, you can almost do all cases, again, depending on the physical condition of the patient. Of course, if there are patients who are elderly and they have, ASA status of 2 or 3 or 4, whatever it is, then you may want to maybe not do all the cases there. Maybe you want to either do that or have a higher level of certification so you can have a CRNA or an anesthesiologist present for those types of cases. But my bottom line here is that I don't feel that the office-based surgery suite is going to take away cases from an ASC. I think you still need an ASC. For me, I do a lot of cornea, as you know, you can tell this is an Eversight talk. So I still do a lot of DMEC and DSEC and penetrating keratoplasty. I can't do those in an office-based setting. I can't even do them in a surgical center. I have to do them in a hospital. So I have a hospital too that I can operate at. I am not going to take away cases from them. I don't think ASCs should feel threatened by office-based surgery yet. I think that this is sort of a relief valve. So if I can do 10 to 20% of my cases in an office-based center, I now have more time in the ASC to be able to do more cases. And as I said, we are seeing more and more patients who need surgery. We're not going to be hurting for numbers of cases. We're going to be hurting for where can I do these safely, effectively, in a way that is, you know, very efficient. And that is the issue. As I said, we have a CON requirement in Illinois. We can still do all of our elective cases, and we have contracts with select commercial payers that we are doing some surgery. Even if we do surgery on a commercial patient and we are not getting a facility fee, we are losing not thousands of dollars on a case. We might be losing, as I said, $300 to $400. And sometimes we can offset that by, if we do these cases that are elective or premium lenses, we may be able to kind of offset some of the losses in the facility by just being able to offer a premium service. But I think this is all changing. And I think if in 2026, CMS revisits this concept, it will be a tremendous floodgate of people who want to have office-based facilities set up. So I'm hearing from a lot of people who are looking now to try to get, you know, ahead of the curve and to try to set up office-based systems, you know, before that all happens. I really think, having traveled all over the world in the last 20 years or so, seeing these facilities in offices, I think this is the most efficient way to do it. And I think we are definitely headed down that road. As I said, it makes financial sense, but it also makes sense in other ways as well. We think that the break-even point is about 250 to 400 cases. If you do more elective cases like refractive lens or ICLs, you're going to probably break even faster. And as I said, I have seen a tremendous increase in numbers of patients that want surgery here. So it is growing our practice, and we have 5 surgeons who are utilizing it now. So everybody's growing, and it's really becoming a significant revenue stream for our practice. As I said, there's comfort in the patient's mind as far as a familiar location, staff is familiar. You can select as a surgeon the equipment you want. You have total control over scheduling. As I said, if you already have a practice that offers refractive surgery, using an office-based surgery for your phakic IOLs and RLE cases is a logical progression. It makes a lot of sense. Most importantly, I think customer service should be at the top of mind. When you do an office-based, it really should be an experience for the patient from start to finish. Because we are charging for a premium service, we have to have the ability to consistently deliver that patient experience that is top-notch and boutique. And if you can do that, I think you're going to see this really, take off. As I said, in a world where ASC time is becoming a lot more valuable, especially for some of our younger surgeons, as I said, we take these cases out of the ASC, we create more room for those cases that must be done in the ASC. If it's an older patient or a patient who has other, physical or medical comorbidities, these are not the patients that you want to operate on in your office-based center. You want to pick those cases where it's the quick, healthy patients and who really will appreciate that precise premium patient experience. How do you transition? How do you start doing this? Well, I think it's a real simple formula that we did. So as I said, over the last probably 10, 15 years, I've been doing less and less anesthesia for my cases, so that, I still probably, when there's an anesthesiologist or a CRNA involved, I only give them about, maybe 0.5 of Eversight. That's it, IV. And then they're mostly awake. I tell them they're going to be awake, and we're talking to them and going through the process. But I've even, before we had the OBS, then started doing cases without IVs. So now we don't use an anesthesiologist in most cases, or a CRNA. I would say most, maybe 50%. And they only get oral, either Valium or Xanax, about 30 minutes before. And you got to talk to them, and you got to talk to them in this local that we give, reassures them everything's going well. You do have to start thinking about patient characteristics. If somebody's a very anxious personality, you'll know this during your consultation. If you try to put drops in their eyes and they're, recoiling and they're giving you a hard time about opening the eye, you may not want to, transition these patients over to an office-based surgery, and certainly not, an oral. You may want to give them a little bit more sedation. So think about that as you go through this process. But this is a great way to do it. And if you start doing this, you'll see. I was a very big skeptic. I am amazed how well people do with just a little bit of Valium. Think about, if you're doing LASIK and Smile and those kinds of things, you've been doing that for years with oral sedation. Most people do great. Now, cataract surgery may be a little bit more involved, obviously, and patients may have a little bit more discomfort than they would with a LASIK or Smile. But I would offer that it's not that much more anxiety provoking, whether you're having LASIK or cataract. Patients don't know the difference. They don't know what the maneuvers are involved. They just think, hey, I'm having eye surgery. I'm going to be very nervous. I get Valium or something for my LASIK, and why can't you give them, Valium for cataract? And the answer is you absolutely can. But this is a good way to transition. This is a picture of our setup here. We have a 3D visualization, which has been amazing. It's been amazing for my back. But it's a great thing. They've really accomplished a lot in terms of the quality of the imaging that's there, and it really is a very immersive process. I think it's going to get better and better as time goes on, but it's really, really good. Again, who should not be in the office-based suite? If someone has an ASA class 3 or more, if they have significant comorbidities, if they're very anxious, if they're already taking a lot of anxiolytics. Certainly, I'm not operating on any Medicare patients in my state with our CON structure. Anything that's complex, I'm not taking it at the office-based surgery. That's going to the hospital. In case I need to increase the level of sedation, I can do that. As I said, our target is about 20% of our cases, cataract, refractive, whatever, should be done in the office space. And that's kind of where we think that it would be very, very beneficial for us from a financial standpoint, but as well as from a standpoint of being able to put a throughput of those patients through our center. What's the disadvantage? Well, again, not suitable for everyone. You may need more additional anesthesia. You may need, in complex medical patients, they should probably go to the hospital. Complex surgical procedures, if I'm doing, reconstructions of the iris and all these kinds, if I think someone has a high chance of having, needs a vitrectomy or whatever else, I probably wouldn't start doing my cases in an office-based surgery, just because you can't supplement the anesthesia as much in case the time of the procedure becomes a little bit longer. Another disadvantage is somebody's got to set this up for you, right? You've got to have the right system for planning, designing, construction, accreditation, staffing, supply management, reporting, electronic records. I mean, it goes on and on and on. And, it is daunting, but it is definitely doable. My advice to anyone who wants to do this is to find a trusted advisor who can guide you through this process. The questions that you need to ask, because as I said, the term office-based surgery is very, very loosely thrown around. There are some companies out there who are saying, well, just you have a 600 square foot room, just throw, phaco in there and throw a bed and go. And that's really not my opinion of what an office-based surgery should be. The facility right now does not have to be accredited, but from a lot of standpoints, from your own medical legal exposure, or if eventually insurance or CMS Medicare start approving these facilities, they're going to have to be accredited. And if you don't keep it accredited, you may face penalties. And forget that, you may actually put patients at danger. I know of a facility that was doing intraocular surgery in an office-based setup, but it was not what you see the pictures that I have. It was basically a room without ventilation, without whatever else. And the patient had a bilateral phakic intraocular lens procedure, and there was a bilateral endophthalmitis. Now that would actually probably drive me to harm myself. And I think I couldn't live with myself if I did that. So we think it has to be done in an accredited facility, has to be top notch. When you're asking your advisors about this, ask about accreditation. Ask also, how are they advising you to do billing? There are people out there who are advising you to bill for patients who are on Medicare, even if you live in a state that has a CON. And they're doing it in a very, I would call, creative way, because they're billing codes that are not cataract codes. And they may be getting reimbursed, but they may also be setting themselves up for scrutiny from the government. And so I would be very, very cautious about performing cases if it is not an accredited facility. And if it's not a Medicare accredited facility, stay away from Medicare. As I said, our goal was to only perform 20%. We didn't want to deal with a situation where, Medicare came back and said, well, we need to pay us all our money back and interest and penalties, maybe risk being kicked out of Medicare, terminated contract, or even worse, go to jail. And so we're doing this above board, by the book. There's plenty of cases that you can do without resorting to shady gray area tactics. And so I think find someone who can help you. If you have questions, please reach out to me. I'm happy to help guide you in the right direction. OBS is the future, and I would say that it's the present. If it's done correctly, it can provide tremendous patient satisfaction. We talked about that. Incremental financial rewards, we talked about that. What we haven't touched on, and what I really didn't kind of expect, I underestimated, just as I underestimated the patient satisfaction, I underestimated the surgeon satisfaction. And it was an amazing feeling the first day where I did cases and I could walk across the hall and see patients and then go back and do more cases. I felt so much control of my life that you have no idea. Over the last 28 years of doing this, I had felt zero control. And now I feel like I have tremendous amount of control, at least for those patients that I'm doing in the office-based surgery center. But it's not to be discounted what tremendous rewards there are for patients, as well as for your practice, but as well as for you and as for your mental well-being. And it's just fun. It's brought back the joy of ophthalmic surgery for me. After doing this for a long time, it's pretty amazing. And so I am super excited about office-based surgery. I think it's going to be here to stay, and I think more and more of us are going to be doing it. But I urge you all to do it the right way, and you will be able to recreate this exact experience that we've had. And it's just been fantastic. So with that, I'll definitely open it up for questions. I want to thank you all once again for being here. Thanks to Eversight for allowing me to talk on this platform about this topic, which I am really increasingly being so passionate about. So thank you so much.
Thank you, Dr. Majmudar. Appreciate you sharing your experience with this cutting edge topic. We have an opportunity for folks to enter questions into the Q&A panel or into the chat. I don't see anything there quite yet. So I have a quick question to get things started. It's kind of open-ended. What would you say, two parts, what would you say was your biggest lesson learned or mistake you made in starting an office-based surgery center? And then part two, what is your favorite part about doing office-based surgery?
Yeah, good questions. Thank you. So, I think the biggest mistake was not doing this, 15, 20 years ago, but the environment was different. We didn't have the right team in place. We didn't have the right mix of surgeons, and it was all just the right timing. The planets aligned, and this is now the time where we were doing it. So we're very happy about it. I don't think we've made any mistakes yet that I can tell. I think that when we built the space, you saw in the first picture, there's 2 rooms. We built 2 rooms, thinking that there might be future growth. And that's probably not, I don't think it's a mistake at this point, but the one issue is that second room right now is not being utilized yet. But I think that it's always better to have more space than less. And the incremental cost of adding another space, now we didn't equip it with all the equipment yet. So in that sense, it's fine. But I think that if I had, in my particular situation with my layout, if we had stuck with a 1 room OBS and maybe had a little bit more room for the pre-op and post-op areas, I would have probably preferred that. because right now I feel like that's a little bit cramped, and that's the only thing. It's a minor thing that I think that we could have done possibly a little bit differently. So that was a little bit of a learning curve, and again, all of us are going to be constrained by the space that we have or that we can acquire. We can't really do more than that. But these are all lessons that we're learning as we go through, and future centers, if we design them, we may take that into consideration. And the second question was, what's the best thing that the most pleasant surprise, would you say? To me, really, it was how two things, really. As I said, the patient satisfaction, how much they love it. I didn't realize, I didn't put a lot of stock into that customer experience, that boutique experience, but it's powerful. Patients really don't like going to an ASC or a hospital for surgery. They love having it in the office-based center. And I also discounted a little bit of what we felt as surgeons, and that joy, that inner sort of peace, and that passionate feeling that we've gotten. And that I really underestimated that. I didn't realize that would be so rewarding.
Well, thank you for the answer. And it looks like we have a quiet crowd tonight. No other questions in the Q&A.
Well, I think this is going to be a topic, as you'll see more and more people, as I hear and I talk about this a little bit more, our experience. People come up to me and ask me, "Hey, I really want to get into this. How do I do it?" And again, the main issue is doing it the right way. And there's a lot of bad advice out there, and as always, and you kind of have to sort through what is right for you and your practice, and what's right in general. And I think that we have a model that we've set up now that has done it in a way, as I said, is very effective in having a patient-centered experience, very cost-effective, but it's also done right by the book, and with patient safety in mind, 100% at the top of the list, but also to the point where we are complying with all regulations. And we think that puts you in a better position going forward, because I think that in the next, whether it's 2, 5, 10 years, this is the way that we're going to be doing majority, I don't know majority, but at least I'd say half of our cataract surgery. And that's a lot. It's a huge uptick from what it is right now. So if anyone's out there even on the fence thinking about this, if you'd asked me 2 years ago or 3 years ago, yeah, you'll be doing this, I would have said you're crazy. The space that we had just wasn't functional enough to do that. But keep an open mind, look at what's happening out there. And I think that you'll find that things are changing, and you want to be on that early curve, the early adoption curve, if you can, because I think you're going to see tremendous rewards on all levels, as I said.
Yeah, it sounds like two things are coming to my mind when you talk. One is the future is now, that old saying, and then kind of the idea of getting in on the ground floor.
Yeah, I mean, look, it's not you're not getting you're not buying a stock for pennies and this is basically, you're ahead of the process, so that there's going to be a tremendous rush towards trying to build these things and get it done. And then that's going to be a slower uptake unless you start kind of now. If you start now, this whole process takes, probably about 8 to 12 months. And then we're in that second now 12 months, where we are now past the construction phase, but now we're in the implementation stage. And as I said, we're still, we've done a lot of cases this year, but we're still kind of on that upward trajectory, but we're learning from that, and it will take time. And I think that, again, partner with the right people to help you through this process. If you can do it by yourself, please go ahead and do it. It's it's daunting, but it can be done. If you have the right team behind you, it's easier. So look for people to help you. Anyone has any questions, they can reach me. And I'm happy to give my experience and guidance as much as I can. I think it's going to be, it is, you're right. It is the future is the present, because it's here and there, and we're really seeing the results.
Great. Well, thank you everyone for logging on tonight. Of course, thank you so much to Dr. Manoj for sharing your experience. And please, when you log out of we had a quick last second question. Perfect.
Sure.
How many total square feet are needed, including ORs, pre-op and post-op, etc.?
Yeah, that's a great question. So It depends on how many rooms you have. There are very specific guidelines. Our center is about 1,400 square feet, and that has 2 ORs. It has a clean room in the middle. It's got a dirty room. It's got a little a small storage / locker room. It has a small little waiting area, which is, again, smaller than I'd like. It has a pre-op area and a post-op area, which is almost sort of blended, because again, we're not doing 20, 30 patients in a morning. We may only have 3 or 4, so we don't have the need necessarily to have so much space, but I would have liked a little bit more. But that's what we can get for about 1,400 square feet. So I think that if you have one room with all the other ancillary areas, pre-op, post-op, clean room, dirty room, storage, a little waiting area, you could probably do it very, 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 very comfortably at 1,000 square feet, maybe 800 or 900 square feet. Just depends on your layout and how you want the flow of patients to happen. If you're going to be doing, for example, if you live in Florida or Texas and you're doing Medicare cases, you might be doing 30 in a morning, and in that case you might want to have 2 rooms. You might want to have a larger pre-op and post-op area so that you can have one patient in pre-op, one patient in the OR, one patient in post, and have that sort of rotational system in place. You'll have to kind of we'll have to work through that information, but basically anywhere from 800 to 1,500 square feet would be for 1 or 2 rooms. If you have more space, if you got 2,000 square feet, you can really make it very, very nice. And so it just depends. But again, our goal is not necessarily, there are requirements for space, but our goal is to do it in a very, very high quality way. We definitely want all of the ventilation to be right. All the flooring has to be certain standards. The walls, everything has to be just according to an ASC. That's my only advice. Just do it as an ASC, a mini ASC, and you can do it for very low cost, and it will be tremendous value.
Great. Sounds like you can do a lot with not too much space. And so when everyone logs out of the webinar, when the webinar closes, you'll have a brief survey. It's just one question. Please take the time to answer that. And keep an eye out for the next webinar, September 25th, applications of AI in cornea with Travis Redd from Oregon Health Sciences University. Any final closing words, Dr. Masvidal?
No, yeah, thank you to Eversight. Eversight's been a great partner of ours for the last, I've been doing this 27 years, and we've seen a tremendous amount of growth in corneal surgery. Obviously, we weren't doing DMEC and DSEC back then, but every step of the way, Eversight has been very, very progressive and working with us to try to come up with new ideas and stay relevant. So I appreciate the partnership with Eversight. So thank you all very much.
Thank you. We appreciate you too. We couldn't do it without you either. And thank you to all the participants. And I'm going to close it out. Everybody have a great night.
Thank you. Good night.